going.
Miss Technology.
Thank you, Misty. There's so many moving pieces with all this technology. It's good though.
Hey, Chad.
Good when it works, right?
Good afternoon.
Good afternoon.
Is it afternoon already?
I know. And it's a Friday afternoon. Which is even better.
Huh. Hey, Julie.
Hello.
Hey, Julie. Caitlin. Getting everybody on. I know we've got a minute or so. We're the early birds.
This day's gone by so fast. I mean, I literally just looked up at the clock and it's noon already.
I know.
Yeah, they're saying good afternoon. I was like, what?
I've never had that before. My phone had a little chime that was a reminder of my Zoom call. Well, that was nice. I'm already on here.
Google knows everything.
Yeah. Y'all, some days when we're busy with meetings, I have to look down and think and just look at what's next? Because I don't know. Oh. That's good though.
I apologize in advance. I'll have to drop off at 12:30 for another meeting. Fridays used to be a nice, calm day. And I have 6 meetings today. Who does this?
Oh, yikes, Chad. No, we had the SGOH meeting earlier.
Yeah, I missed that one for a conflict with another meeting.
Yeah.
And you both.
Oh.
Hey, Scott.
Hello, Dr. Gibson. How are you doing? Good to see you.
Good. Haven't seen you in a while.
Yeah. Been a while. How's it been?
Nicole?
Good to be back.
Yeah.
Yeah.
Old home time, because I've missed this meeting the last couple months.
Me too.
No worries. We're so glad y'all are here and on with us. Well, all right. It is a little after 12, so let me start with saying a couple of things. One, this is not just this formal format. We want everybody to be involved and participating. We want this stakeholder work group really to be beneficial and help us address some of the issues of CoCM. And, that's looking at current status, looking at resources, looking at things can bring this forward. If we decide we need to be bringing CoCM forward. And so just want to make sure that we are pretty informal because we know that you guys have lots of amazing resources, ideas, programs, things that are happening across the state. So we definitely want to hear about that. And then another housekeeping issue, we want to remind everyone we will be recording these meetings. And so they will be posted to our CoCM site We've created a CoCM site for this project on the ABIN website, and we will be posting these recordings. We had a glitch last month and we did not get it recorded. However, we do have a placeholder with the agenda and the minutes. And so we'll continue to do that. We'll have a recording, the agenda and the minutes. This way, we know people are busy, and if someone's out of town or has to miss a meeting, you can catch up with us by quickly looking through the minutes, or if something was of interest, there'll be a recording. So with that, I'm going to go ahead and just give a quick update on the state CoCM grant. So the state was awarded a CoCM project, and part of that project, they've developed an executive committee, and the executive committee will be meeting monthly. We had our first kickoff meeting. I can't remember if it was last week or the week before. That tells you how fast time's flying. We've recently had our first executive committee meeting, and it was a great meeting, and it was an opportunity for us to go over the goals and the objectives of the grant, talk about some outcomes that we're hoping for by the end of the project. And really the goal was to level set, to familiarize everybody with the organizations participating, and then to hear about the goals. Just want to remind everyone the participants for that project are Medicaid, UAMS, Boston Mountain Rural Health Clinic, and Eastern Arkansas Family Health Center, and AFMC is going to be joining the project, and then us. And we're going to be doing a lot of training, education, and technical assistance pieces on the project. So with that, I'll pause and ask if anybody has any questions, but the meeting was pretty much an introduction to the project and kind of a level set of what things are going to look like for the project. Okay. And if not, we will go to the next item. Next item on our agenda. We've also, just so you all know, we have developed an agenda and invited Tisha Dean from UAMS to give an update to this group on the things that are going on at UAMS. Unfortunately, she had to be at a conference today, so she's unable to join us. And then we are asking, we've got Dr. Gibson on to give us local and national updates of what's happening. And then we've got David Jones from Medicaid that can also give us updates. So with that, we're going to turn it over. I think, is Dr. Gibson next on the agenda? No, yes.
I'm not seeing an agenda. I don't mind going, but I don't want to jump over David.
Well, we'll ask Misty. I don't know, Misty, if you could flash that up for us for a second. This will keep us on track. Not to put poor Misty on the spot real quick. Okay.
It is.
We'll turn it over to Dr. Gibson, and then we'll turn it over to the rest of the folks.
All right. Y'all know I always like to share some things. So I wanted to share some of what else is going on around the state as well as around the country, especially to let us know that we in this group and we in the grant are not doing this in isolation. That like everything in integrated care that we've tried to do with ABAN is to go and learn what's the best practices out in the rest of the country and in other organizations, as well as to build relationships. So I just wanted to share some of the things that are going on around the state. Forgive my busy slides, but first thing I want to talk about is Arkansas Blue Cross Blue Shield. Y'all know that now I'm the medical director for behavioral health there, so I have an inside roadmap there. And Blue Cross has been supportive of integrated behavioral health for a long time, but certainly is continuing that behavioral health is a primary focus for the entire company and all the lines of business. There has been a white paper released where they analyzed some of the claims that show that when there is behavioral health engagement for patients, that inpatient visits decrease, ER visits decrease, and the per member per month cost overall decreases. So they're really looking at the claims and seeing that from a payer perspective or an employer perspective, that integrated behavioral health has high value. And I was just reminding folks in terms of Arkansas Blue Cross shared some good data with us when we were trying to get the legislation passed, where it showed that Blue Cross had looked at their claims from 2020, 2021, 2022, and seen that by paying for CoCM, that they saw similar responses in decreased overall cost for the members who were involved in CoCM. Arkansas Psychiatric Society, I'm the president of that at this point. Just want to let you know, Arkansas Psych Society is been very involved in getting the bill passed, as well as continuing to provide education to psychiatrists and people around the state. And I just talked to somebody from outside of the state. They were interested in coming. But our annual meeting this year is Saturday, June 1st. The topic is Untangling the Web of Addictions. And Dr. Bill Beecroft will actually be one of the speakers. He is from Michigan Blue Cross Blue Shield, and his topic will be on CoCM in substance use disorders. So he will be coming to Arkansas to share his expertise. And Michigan Blue Cross has been supporting and providing incentives to practices for several years to provide collaborative care management. The APA, American Psychiatric Association, we've talked about this before, but they do continue to have active trainings on the site. And then there's some new trainings showing use of collaborative care in special populations, including geriatrics, as well as for pediatrics, maternal, and substance use disorders. And we know that in the state and almost everywhere, people are trying to figure out how to solve the youth mental health crisis, as well as maternal morbidity and mortality. So the value of seeing that there's some evidence for these populations is really important for us in this group. Also wanted to give a shout out, and Scott could speak to this, but the Arkansas Medical Society just published their journal, and has a work group that has produced a policy statement that is calling for treatment of obesity, addiction, and mental health diseases as disorders as chronic medical diseases, and wanting to increase education and decrease stigma for all of these disorders, so that and there's support from multiple medical organizations around the state to be part of this. So I think this is very significant that not just behavioral health, but all physicians and medical societies are trying to improve overall whole health care, as well as recognizing the value of behavioral health treatment. Some of you may have been in our ABN webinar yesterday. The American Medical Association, Chris Botts gave a presentation about what's happening at the AMA level. The AMA has a BHI collaborative, that includes all of these medical organizations, and they've been working, I think, well, since 2020. And there's a significant number of resources on the website, and the recording will be on the ABIN website. And there's some great information about it's challenging to implement integrated behavioral health and specifically CoCM. And so we can learn from what they've been learning and find tools to help people be successful, as well as finding what are the barriers to sustainability. And you can see that they're seeing that sustainability, it does include financing and the payers, and then it includes getting practices trained, but also policies and the employers who are purchasing plans to understand the need for BHI and CoCM. Just sharing this, that I went to the Mayo Integrated Care Conference. Mayo has been doing integrated behavioral health for more than 15 years, and this is their model. And they are continuing to evolve and grow, and they very much use a blended model of collaborative care management, as well as using co-located therapists in their clinics. And so they're continuing to be a leader and show that this is a model that can be sustained, and that they will share their best practices with folks. This is a webinar. North Carolina has been trying to implement integrated behavioral health and specifically CoCM for the last few years, and have this is a webinar that was a recording that you can watch and get the PowerPoint, but they released a white paper, an executive summary that shows their roadmap to success in North Carolina in terms of integrating CoCM. And they developed a CoCM consortium of multiple entities within their state. And this is kind of similar to what we're trying to do here. And you can see North Carolina Medicaid is there, several of the medical associations, but community care clinics, and then some of the plans, including Medicaid health plans and commercial payers. So they can be a really successful model for us to learn from, so we don't have to reinvent the wheel. The Bipartisan Policy Center had a webinar last month showing some of the needs that have been identified, that it's the workforce is really an important piece to making the success for not only specialty mental health, but integrated behavioral health. And so they've also released a paper in December with some of the learnings that they have. And then, although Tisha is not here, I'll speak up for her that Tisha is the co-chair for the Collaborative Family Healthcare Association's CoCM Special Interest Group. And Dr. Laura Sederi is co-chair, and Monica Harrison with AIMS is in this. So this is a place, CFHA has some great resources, and we can learn from them. And then the AIMS Center has been showing evidence and teaching and training for more than 20 years. And they've revamped their website and have some great resources as well. So that is a speed drive to see that it encourages me that we're not alone, that we don't have to know everything, but that we can learn from others that are out there already. And but all of the places where we're learning, we're finding it's extremely important to have people who are in the state who understand the model and can work with the practices who are in the state and can help people solve issues on a provider to patient level, as well as the business side of making this successful and sustainable. So kind of both, having national, but also having local. Thank you, Kim.
Thank you, Dr. Gibson. Any questions about any of those updates? Any questions for Dr. Gibson about things that might be happening? Comments, thoughts? Well, I do have a comment, Dr. Gibson, which is you are extremely busy going around. She's always either listening to a webinar, attending a conference, getting information, getting up-to-date research and information. And so I'm so grateful you're able to share that with us and to keep us updated, because it's really, there's a lot happening in the country around behavioral health integration. And so I'm so grateful we have a resource that, which is you, to keep us on track and let us know all the different things that are happening. And as Dr. Gibson said, we did have Christopher Botts on our webinar yesterday, and it was really great to hear from him that the AMA is supportive of behavioral health integration, that new specialty disciplines are joining, and they are saying behavioral health integration is really important for us to be starting to have the conversation and think about. I'm hoping becomes mainstream in our healthcare settings. That's also really important. And then one of the things that he said that stood out was, and y'all have to help me because I don't have my notes in front of me, was it New Mexico that has waived the copay for behavioral health? And I thought that was really interesting. So the first state, they're waiving this additional copay. And I think that's something for us to pay attention to and for us to be aware of. And yes.
Did he say waive copay or waive co-insurance?
Or was it cost sharing? The cost sharing.
Because one of the big issues that we've seen in places that have high deductible plans, it's actually against the law for the payer to say, oh, well, you don't have to pay your 20% if that's what your policy is. And especially a lot of us now have very high deductibles, like, you know, $5,000 to $10,000, depending on what your plan is. So yeah, Verna's saying it's a violation of the contracts, and that's federal law, I believe. So trying to figure out how, because that cost sharing piece makes people, you know, a lot of people that are really good candidates for CoCM are very functional. They're employed. They're not going to take time off anyway to go see a specialist. So they often are saying, well, no, I don't think I need, I'm not going to talk on the phone with somebody and get some CoCM because I really don't want to pay, because I'm going to have to pay, you know, $5,000. So I know that other payers are trying to look at that and figure out how to overcome that barrier. The copay is a significant factor, but it's the co-insurance and high deductible.
Yes. Thank you. Which is really encouraging, right? That we're starting to get some attention and some movement, and we'll have an opportunity to watch them and see what this looks like. Is anyone else hearing that out in your practices? Maybe patients that are, I'm looking in the chat, Verna. Yes. Now New Mexico needs to pass CoCM codes. Absolutely. Hopefully this prompts them to start moving in that direction. But I'm just curious, because we know we've got some folks on the call who are doing this in their clinics. As you're presenting CoCM to patients, how are the patients responding? Are they receptive? Are they hesitant if there is a copay charge? I don't know if anybody wants to talk about that.
I was
we
gonna
have,
jump. Oh, sorry.
go ahead. Go ahead.
I was just going to say quickly that this time of year too, remember many plans have been reset. So people have new deductibles starting. So you're going to see much different dynamics now for the first quarter than you might other times. It's a big problem.
Yeah.
And I was going to say, Kim, here at White River, we've absolutely had people that felt like they needed to opt out due to that. Many times.
Thank you, Rachel, for sharing that. And thank you, Verna, for the reminder. This is early, the first quarter, and oftentimes people have not met their deductible. So that's something for us to keep in mind as well. Cost could be a barrier. One of the things that they also mentioned and talked about is sometimes CoCM, if we include it in value-based contracts, that can be helpful. Don't know if anyone has any thoughts on that. Just thinking about the value-based payment work group that I'm on, and then Chris mentioned this yesterday as well. So just wanted to ask if anybody here had any thoughts on that.
Kim, I'm eating lunch, and so I'm going to go back off camera in a minute, but I'm coming in late. Is the question, why is there not more uptake of value-based contracts in this space?
That's a good question.
That is a good question.
Well, the answer I would give is traditionally, many mental health providers have not felt that being in network and being reimbursed by a payer has provided an adequate revenue stream to be in that network. And so there's a couple of thoughts about value. What is value? It's getting a good service with a good outcome at a fair price, if you boil it all down. So I think the answer to that is dependent upon, are payers willing to pay for care that is good, and how do you measure the outcomes? Is a good outcome stability of a condition? Is it improvement of a condition? Is it a reduction in the slope of deterioration of a condition? You know, if you have a bad gallbladder and you do surgery, it's pretty cut and dried, no pun intended. But when you're dealing in this area, it's so difficult to measure value. It's hard then to set up a value-based payment model. Those are my thoughts.
That's what, no, that's really important. Thank you. And thank you for sharing that with us. And you're right, this can be challenging to, traditionally behavioral health has been challenging to measure, but hopefully with CoCM, with the registry, we could show some outcomes, and show them maybe a little more black and white than typical behavioral health things have been hard to measure.
So the best thing we can do with CoCM is recognizing the impact of behavioral health issues on chronic health care conditions. And if you can look at cohorts that have access to CoCM and then use as a proxy benefit by seeing a reduction in the overall cost burden on management of those chronic conditions. I mean, there's a lot of research that's already shown the impact of unrecognized BH on hospitalization, other costs of chronic care management for regular medical conditions that are not truly BH. So that might be a way to go about, you know, showing values by looking at the overall cost of care for the associated chronic medical conditions when you associate care management for BH on top of it.
Any thoughts on that?
That's some of the data that Dr. Aaron Novotny had looked at in preparing that information for the legislature where they were showing that the people who had CoCM claims and that their total cost of care was higher, and that there was a cost savings. So value is not always about cost savings, but you can assume that, or you may assume that people who are not needing high cost services are doing better. And then, so for cost savings being one of the values that can be demonstrated, in that Dr. Novotny has been able to pull some of that through from the Arkansas Blue Cross data.
I might think this is something that this group could do, given that there's some folks doing CoCM, to partner with payers to actually say, how many patients do we have collectively in collaborative care? What ability do we have to track outcomes and to get that data, right? Because some systems may be able to run it on their own. But if we did that collectively, right? Because it's one thing if, this organization does it and then Concert does it, but if we did it as a collective from providers across the state, it might be helpful for the world at large, but also for advocacy efforts in the state. So just putting that out there.
I think as a provider, I can think of situations where patients have had maybe multiple in and outs of the hospital, inpatient stays over and over. And I mean, everybody can probably picture these people in their mind, and you start to be really aggressive in that follow up, and you're doing these things. And it's like you look anecdotally and say, oh man, this was so much better, but you didn't go into it with the outcomes, into it with a structured approach. And I think that's maybe where we sometimes miss, is that, we tend to kind of look more anecdotally as far as, instead of planning ahead.
Mm-hmm. And at the same time, Julie, that's a great point. Anecdotally seeing individuals that you've made an impact on. I would say I also see the impact of individuals that I can't get into treatment very quickly. And even as a psychiatrist, someone will say, hey, my brother, my son, can you get them in? And I'm like, well, who's their primary care clinician? And they'll be like, and I'll say, oh, well, if they had BHI and CoCM, they could go see their primary care clinician today or tomorrow, do the evaluation, have a care manager do more behavioral health evaluation for the PCP, and then to be able to have consultation with a psychiatrist, within 24 hours, so that the PCP and that team could take care of the patient. Because we just can't get people in, and most people cannot wait the 2 to 4 months it takes to get in to see someone for mental health, whether it's and people may not know if they need medication or therapy. So that's the value, that not only could this be cost savings, but it can be much more rapid access to a level of care that can help really triage, to say, no, you're fine to stay in primary care, and get you set up with the resources, and even identifying social service needs that they may need that could provide some of the answers. So
I think that's so important. And, I think sometimes when someone enters care, just thinking from traditional behavioral health, how do we know they're getting better? It's self-report, right? And based on what's going on that day, that could affect the report. But I think that if we're doing something like CoCM, and there's check-ins and there's screeners and there's ways to measure, I think that it helps us know, are people getting better? And if not, what do we need to do differently? And so that's another piece of this that I really like. Okay. And great suggestions, Verna. One of the things I also wanted to say, part of this CoCM grant, one of the things that is going to be happening is there will be a program readiness review. And so for the participating organizations, they'll be looking at the current status of CoCM within their organizations. Are there any barriers? And then helping to identify what are the training needs? What training needs do we have at the state level? What training needs do we have at the clinic level? And also what training needs do we have at the provider level? And so once we get that information, we'll start to work with some experts, including some folks we have on this call, to help us develop some training pieces for CoCM. So
I would jump in and just say one of the big problems we're still seeing nationally, and actually recently I was talking to the AIM Center because we've learned something about launches and being more prescriptive, is that if you look at, we always say, oh, the percentage of primary care patients that have a behavioral health need is so high. And yet the average number of patients by PCP where there is collaborative care is generally in the single digits. And so we're really starting to think about what does it take to actually get primary care providers on board to understand collaborative care, to really sort of reconcile that, right? Because then you talk to them, they're like, oh, I love collaborative care. And you're like, but you only have, 9 patients and you have a 1,500 person panel. And then you find out that they really are still thinking about more traditional behavioral health and don't actually understand the treatment choices in collaborative care and how to really conceptualize it and do it. And you actually do need to do like another, not just a 101 training, but actually like some sort of more prescriptive kind of follow-up. And so I put that out there just to really bring attention to it, because that's still where we're missing the boat in a lot of implementations. And so just putting that out there.
So Verna, everybody on the call may need help because I realized I was on camera cramming things in my face during lunch at my desk. So I apologize if you're wounded after that. But, a thought on that, because remember, I was in medical education before I came to Blue Cross. And I think the only way you change that is you have to introduce it into the educational model, that you can't just kind of expect that you're going to go into a primary care office or a medical care delivery entity and convince them that they need something that they don't know about. They haven't needed so far, so why should I bother now? I think the successful way is to introduce it into the residency programs.
I totally agree. And thank heaven CMS issued new guidance in December, because many of the academic, hospital-based sites, oh my God, excuse me, were wedded to the fact that they couldn't bill the CoCM codes. And so that actually just got fixed in the last 2 months.
Patty, is there any, I know you're in the grant, but I haven't studied where the actions are, but is there any attention toward the regional programs in the grant?
Yeah, UAMS and Tisha Dean are a very large site. And I think the intent is to get CoCM and to use the grant into all of those AHEC sites. And also Dr. Creletti is on the executive committee and will be directing it and very actively involved. So UAMS and that training site. So hopefully not only training for primary care clinicians, but also the psychiatry.
Great.
Verna, I was going to ask, what did you just say CMS said in December about changing something for the residency programs? Did you say there's some new requirements for the residency programs, or?
No, so there was a lot of the compliance people were stuck in some of the big academic hospital-based sites, many of which are teaching and training. in that they weren't able to build the codes because there's service location 19 and 22. And because the guidance says incident 2 and there's guidance that said they couldn't bill incident 2. And so we got CMS in December to reissue new guidance and their FAQs to really address that. And then I have some additional guidance if people are stuck. But that was a big problem that prevented a lot of the larger academic medical systems for doing collaborative care in some of their training facilities or hospital-based sites.
Can you share that guidance with us?
I can.
Okay, thanks.
It will be in your email in about 18 seconds. And if anybody wants more information, I now know more about this than I ever wanted to, in terms of hospital-based billing. And so I can give you additional information, but I'll share the updated FAQ.
Now that's lightning fast. Thank you, Verna. All right. We've also got David Jones on with us. David, I don't know if you have any comments. I know we haven't really done much yet, but wanted to give you an opportunity to give your thoughts and comments.
Well, right now, we are in the middle of our continuing application process with the SAMHSA grant. It was just awarded, and now we have to do a continuing application. I can let you know it's been a learning process, I think, for us and UAMS, trying to figure out who's responsible for what when it comes to all the documents that were required. And so luckily, our federal partners are very understanding. And so even if we're delayed in submitting it, they are aware of it and they understand. And so that's one good thing that we have is some great federal partners in this grant that has been really helpful for us. But that's about everything that's been going on for me this week. It was being consumed by that, but hopefully we'll have it submitted very soon.
Well, thank you for that update. And that's an important piece of this because even though we've got the grant and we're excited and we have these wonderful goals and objectives, the reporting piece takes a lot of behind the scenes manpower and even not behind the scenes. And so it takes a lot of work and effort. And so, David, I want to thank you for doing that for this project with UAMS because I hear you. I feel your pain on, some of these grants that we have. The reporting is a huge piece. So thank you for doing all that and for giving us the update on what you're doing. Okay. And then we have Caitlin Johnson. And I know Caitlin, I feel like I'm gonna do just a quick introduction because we've had you start the first part of the year, but we didn't have everyone on the call. So we've got Caitlin Johnson, and Caitlin is an LCSW, and she has been working with the ABIN team. She has joined this project as a project manager, and she has experience working as a behavioral health behavioral health consultant, as well as the behavioral health care manager piece. So that's where I'm getting tripped up, right? We have now all of the acronyms. We used to be calling it care coordinator, but now we're calling it behavioral health care manager. So I want to introduce Caitlin. She is instrumental in helping us with this project and really has been with ABIN since the beginning. So with that, we've got Caitlin on the agenda, and she's going to be telling us about some CoCM coming attractions. So I'm going to turn it over to you.
Yeah, that was so nice. Thank you. I didn't expect to be flattered this morning, so I appreciate that. Yes, I've got a lot of background in behavioral health intervention. Basically, one of those people that you just plug me in, and I'll do whatever you need me to do. I'll go see patients and be wherever you need me to be. So, like Kim said, I'm going to just share a couple of CoCM events that are coming up. But first, I'm going to put some of the links that Dr. Gibson referenced in her slides. So in case anyone wants to go ahead and look at those now, of course, they're going to be in our notes that we send out. But if you want to get a jump start on some of that education, we are all about that. So you are welcome to hit some of these links now. And that may have put it all together, but it should, once you copy it to your browser, it should work. Okay, so two of the big events that are coming up. One of our conferences that we're keeping an eye on is our friends over at CFHA, which is the Collaborative Family Healthcare Association. They are having a virtual conference in April. So that will be, and I don't know, let me see. Can I share my screen real quick? Is that okay? Okay, make sure. Okay, so they are going to be having that virtual conference in April, and we know that they are big advocates for CoCM, so they are going to have some talks on those. It looks like April's conference is going to be about how to work with the administration on making these changes and implementing some things. So that's a 2-day conference, and we'll obviously put that link in the notes as well. And of course, they do have their in-person conference coming up in October, but there's not too much information on that because we are a little ways out, and I think they're still doing proposals for that. So it's definitely something I would put on your radar. Anytime I go to anything by CFHA, they're very interesting, and it's very, very educational, very helpful. So definitely keep that on your radar. And then of course, what kind of ABIT employee would I be if I didn't mention our BHI conference, right? So we've got that coming up also in April. And that is going to feature, I mean, it's an 8-hour day worth of so much information. It's going to feature several people who talk nationally about behavioral health integration. We're going to have Dr. Sadari there, who is someone who is such an advocate for a blended model, and it really provided a great webinar for us a couple months back on how you do both PCBH and CoCM in a healthcare system. And I do want to point that out that is still on our ABIN website and available for review. So we'll also have Dr. Horowitz, and we'll have Dr. Martin, which is an Arkansas-based physician. She is really an advocate for medication-assisted treatment, and she is especially in rural areas, and she is what I call one of my favorite type of medical models, is where she gets out into the community and she goes in and sees her patients, and she is doing she may have already started it, the mobile unit for medication assisted treatment. So she's going to come and share her insights on that. And then of course we'll have a discussion with Donald McDonald, who is just a wealth of knowledge when it comes to peer services. And he's going to share with us some of the things that we can do in Arkansas and our own communities to help encourage that practice. So that registration is live. It is April 11th, and it is at St. Vincent's in Little Rock. We've got a nice little countdown here. So that is just another one of the CoCM events that are coming up. I think you're going to be able to get a lot of information at one time about CoCM and kind of be updated on what's going on in Arkansas in addition to these meetings. So those are some of the things going on. Well, those will be in the notes, and I knew Verna would have something to give us on education. Looks like AIM Center is doing a conference on June 7th. So let's go ahead and make sure we get the link for that, Misty, if we can, and send that out in the notes as well. So, and I'm so glad that you did that, Verna, because my next thing was, if anyone knows about any educational opportunities, please send those to us. We'll make sure it gets to the listserv. If it's something that's time sensitive and people need to know to register for it before our next monthly meeting, let us know and we can get that out to people. So I'll hand it back over to you, Kim.
Awesome. Okay, thank you, Caitlin. Lots of updates. Thank you, Verna. AIMS always has wonderful information and resources. Any other thoughts or information? Okay, well, I think the key takeaways are to know a lot is happening nationally as well as locally about CoCM. And with this grant, I think it gives us here in Arkansas a unique opportunity to provide some training resources to look at, some of the information. Hopefully it's going to take a little time, but we get a chance to look at outcomes for the program or the primary care practices that are participating in these pilots. And I think once we get off the ground, we'll start to have some things to sink our teeth into. So we're excited about that. And we will keep you updated. We'll be attending these monthly executive committee meetings. We'll be bringing information back. We'll also bring information from this work group and bring it back to the executive committee. Our hope is that this work group really serves as an opportunity for us to share with anybody in Arkansas what's going on with CoCM. If they have an interest, please join, and we'll keep this going. So with that, we'll give you 10 minutes back to prepare for your next meeting on a Friday afternoon. Thanks